ACS. I have no conflicts of interest. A lot of the data comes from the 2014 AHA, ACC, SCI guidelines for management of non-STEMIs and also for STEMIs. This is a very important slide, which is a very busy slide and hard to read, but this is what we talk about in management of acute coronary syndromes. This is the algorithm for what we look at. And this is what we went over 2 weeks ago. You know, non-cardiac chest pain, well, look for the real diagnosis. If it's chronic stable angina, like we talked about, typical angina, that is, then you treat it as typical angina. What we're dealing with today is possible ACS, definite ACS, and you see definite ACS STEMI, which is going to be diagnosed by the EKG, or a non-STEMI, and then if they have significant EKG changes, ongoing pain, positive cardiac markers, or hemodynamic instability, you immediately drop down and admitted in the hospital and manage per the ischemic pathway. But if you don't have these things, and it's kind of a non-diagnostic EKG, but you're worried, their troponins aren't elevated, I observe them. And this is kind of our chest pain pathway that we go through. And if they don't have any other pain, or they continue to have pain, then you can schedule follow-up studies and consider that they are ACS and plug them down here. If they don't have recurrent pain, then you can treat them like this with a stress study, consider LV function with an echo, and these can all be done as an outpatient. You don't, just because the patient, it comes to the ER with chest pain that we're called for, and we think, well, it might be, doesn't mean they have to be admitted to the hospital. Really doesn't. In fact, it shouldn't. If they come in, their EKG is unexciting, their troponins aren't elevated, they have no more recurrent pain, get them the hell out of the hospital. But make sure that they are followed up in the office, and not in a week, not in 2 weeks, because it might be an ACS, it might be brewing it. They need to have a stress test, in my opinion, within 72 hours, which makes it hard on Friday. But it can be done. But every other day of the week, 72 hours is easy within Prairie. So, and you have to document that, and you document that if you have recurrent pain, come right back to the ER, and then they get readmitted because they had another episode of this pain. But, they can go home. Patients don't want to stick around and be admitted Friday and stick around all weekend to get a stupid stress test or be doinked around with. So let them go home. If they say, oh, I don't know, I'm scared, keep them, right? Because they're the ones going to lawsuit. Well, I told them I didn't want to go home, and you guys said, well, it could be acute coronary syndrome, don't know in the chart. And then they made me go home, and then they had a heart attack and died. So, but if the patient says, yeah, doc, is there any way to go home? I need to smoke, and I want to get out of here, and da-da-da-da-da-da-da. And they've had no recurrent chest pain, their EKG is unremarkable, and their troponins are negative, let them go home. Make sure they're on aspirin, put them on a beta blocker, put them on a statin, and send them home. But make sure they have a stress test Monday, Tuesday, or whatever day of the week so that we can follow up and do due diligence on them. But, so that's an important thing to do. Everybody else in acute coronary syndrome world gets admitted to the hospital and gets managed. I actually had one of these patients 2 weeks ago that I didn't bring as a case study, but a little old lady, we knew she had disease, she came in, she had clearly angina, it was, it increased in CCS class from 3 to 4, but once we got her in, we got her a little bit more beta blocker, got her blood pressure down, she ruled out, she didn't have any more pain, and I was gone. She wanted me to do her a heart cath. I knew that she needed a heart cath, right? I didn't do the stress test, so I let her go home and brought her back. I think 2 days later when I was in Decatur, I did her heart cath, I put her stents in, she did well. So this is perfectly legitimate. You got to document everything, but this is a good pathway to follow. Everything else gets a benefit. And this is right out of the guidelines, so you guys ought to look at this. I mean, it makes sense, it's very guideline directed, and it's good stuff. This is a slide I put in primarily just because it's in every ACS slide, but this is the progression of coronary disease from normal coronary arteries to oxidized LDL into the wall, to forming a plaque, to plaque rupture, and either it clots off and causes a STEMI, or it closes over and gets bigger and develops chronic angina. I just felt I had to have that slide in there because everybody has that. Now we'll move into Class 1 and Class 3 as we talked last time. You only need to know Class 1 or Class 3. Class 1 and Class 3 are standards of care that you need to know. All Class 2s are, yeah, you can do it, maybe it's more opinion. But if you know Class 1 and Class 3, you pass boards and you take good care of patients. So as these slides go through, anything in green print is going to be Class 1, anything in red print will be Class 3, don't ever do it. So, assessment evaluation of acute coronary syndrome. Risk stratification to determine the need for hospitalization. High-risk features include ongoing chest pain, severe dyspnea, syncope, near syncope, and palpitations. If patients come in with this stuff, you worry, and they probably should be admitted most times. EKG has to be done within 10 minutes of presentation in the emergency room. That's a national guideline, and every emergency room should adhere to that. I don't know what our numbers here in Springfield are. I know in Decatur they are in the upper 90 percentile in patients that present with possible ACS or getting their EKGs. Then it goes on to say that you should repeat the EKG every 15 minutes if the first one is non-diagnostic and the patient has ongoing symptoms. They may present, they've got symptoms that you think is angina or acute coronary syndrome, their first EKG is unexciting. 15 minutes later, they're still having chest pain, repeat the EKG because they might have now converted to a STEMI. Otherwise, they go up to the floor and they're treated with morphine and no one checks another EKG, and then we find out, oh my gosh, they had a STEMI, and now our door to balloon time is hours, if not days. So that's in the guidelines, it's Class 1. So if the first one is non-diagnostic, and, that should be capitalized, and, the patient has ongoing symptoms you're worried about, repeat the EKG Q15 minutes during the first hour to determine what's going on. This isn't done very often, but it should be. Troponin I at presentation and 3 to 6 hour symptoms onset. With the troponins, the high sensitivity troponins we have now, I think most people are doing 3 hours the check. So the first troponin is negative. You're going to keep them around at least for obs or admit them. Get another troponin in 3 hours. Typically, if the first troponin is negative and the second troponin at 3 hours is negative, meaning not elevated, they haven't had an MI. They can still be unstable angina. But they haven't had an MI, so quit ordering troponins. I mean, quit ordering, I hate ER docs, hospitalists, nurse practitioners, PAs, cardiologists, everyone under the sun who's getting troponin after troponin after troponin. I don't care. In my opinion, if the first one is positive, don't order a second one. Everybody in the room except for me is a woman. You come to me and say, I'm throwing up in the morning and I'm putting on weight and I'm having active, unprotected sex, and I do your pregnancy test and you're pregnant, I'm not going to repeat the pregnancy test tomorrow. You are pregnant, I know it. So when the first troponin is elevated, I'm going to say, gosh, you're having an MI. I don't need another troponin. I've made my diagnosis. Don't draw it. Now, some cardiologists will say, well, but how high the troponin goes is a prognostic indicator. Well, you're right. But if the troponin is 1, I'm going to treat them, dual antiplatelet therapy, statins, beta blockers, ACE, aldosterone if they need it, imaging, cath lab, the whole ball works. And you know if their troponin is 35, what I'm going to do? Exactly the same thing. So I don't order a test unless it's going to change how I treat my patients. So once the troponin is positive, I don't want any more ordered, and I'm going to give the same quality of care to that patient if it's 1 or 38, or if they've got serial troponins going up. don't care. Guidelines say troponin I at presentation, and then one at 3 to 6 hours after the onset of symptoms if the first one is not elevated. Questions on that? STEMI EKG criteria, you all should know this. This is something that I would expect all our Prairie APPs to know. This is a point of miscommunication with the emergency room all the time. New ST segment elevation at the J point and two contiguous leads, not one lead and not 2 leads, but they're separated by 5 other leads. It has to be 2 contiguous leads of greater than 1 millivolt, read 1 millimeter, but in leads only other than V2, V3, I would say clinically V1 through V3. But in V1 through V3, as you see here, it's got to be higher. The ST segment elevation has to be higher than 0.1. So you occasionally get, this patient came in, they tripped, fell, and sprained their ankle. We got an EKG. We're calling a star 90 because they have 1 millimeter ST elevation in V1 and V2, V3. Well, the patient's not having any chest pain or shortness of breath. It's not a STEMI because, well, if they're men over the age of 40, it has to be 2 millimeters of elevation in these leads to be considered a STEMI. And in men less than 40, it has to be 2.5 millivolts or millimeters of ST elevation. In women, it has to be greater than 1.5 millimeters. So you guys need to know this because if, let's say a patient comes in with whatever symptoms and V2 and V3 has 1 millimeter of ST segment elevation, and you pull the trigger and give them thrombolytics and they bleed in the head and they sue you, they're going to get some yahoo like me as an expert witness. I'm going to say there was no indication to give thrombolytics in this patient because they did not meet the guideline directed accepted EKG criteria for a STEMI. You gave thrombolytics, you obviously don't know how to read EKG, and you just caused the patient a disastrous stroke. And you're going to feel rotten the rest of your life because you just caused someone a disastrous stroke. So you need to know these criteria. It used to be that we said for V1, 2, and 3 it had to be greater than 2 millimeters for everyone. I think this just complicates the issue a lot when you put this. But men this age or men that age or women, oh my God, drives me crazy. But it's based on data, it's based on guidelines, so you just need to know it. New left bundle branch blocks, as we all know, can be considered a STEMI, and true posterior MI can present as a STEMI or true posterior MI, which involves all those other leads that we never look at. Moving on again, assessment and evaluation of coronary syndrome, class 1 and 3. Further troponin levels should only be ordered if initial troponins were normal and, capital N, clinical situation changes, such as recurrent symptoms or new EKG changes. That I don't complain if you get another troponin level. Risk scores, TIMI or GRACE. Most people use TIMI because GRACE is a little more onerous to do. Should be applied to all patients with non-ST ACS, unstable angina, and non-STEMIs. You don't need to risk stratify STEMIs, so don't worry about it. Here's the big one in red. CK and CKMBs are not useful for the diagnosis of ACS. So if you draw a CKMB or a CK or a myoglobin, it's class 3. And it's class 3, you aren't supposed to do that, don't do it. And when other people order that, recognize that they aren't up with the guidelines. So all of a sudden you've got to be a little worried about what they're sending you. It's class 3, don't do it. No emergency room in America should be doing it. It's class 3, shouldn't be done. These are the TIMI risk factors. How many of you have done appropriate use criteria calculators? Raise your hands. Who's done AUC? Okay. To do AUC for non-ST ACS, you got to do TIMI risk score. It determines if this is an appropriate cath or an inappropriate cath or an undecided appropriateness cath, and same for intervention. If they're older than 65, they get 1 point. If they have 3 risk factors or more for coronary disease, diabetes, hypertension, hyperlipidemia, edemia, premature coronary disease, tobacco use, they get a point. prior documented coronary artery disease with a stenosis at least of 50%, they get a point. ST segment deviation, depression or elevation of 0.5 millimeter, get a point. 2 or more episodes within the last 24 hours. They come to the ER, well, did you have any of this? Yeah, I had some yesterday, just like this. It wasn't as bad, it didn't last as long. That counts as 2, and that gets a point. If they've been on aspirin all their life, or for the last scale, if they're on aspirin and they come in, that gets a point. And then obviously elevated biomarkers gets a point. So how do you interpret this after you score them? Here you go. 0 to 1 point and 2 points are green, that means they're low risk. 3 and 4 points are yellow, intermediate risk. 5, 6, and 7 points is high risk. Well, how do you know it's high risk? It comes from the TIMI trials, and it's looking at the chance of all-cause mortality, new or recurrent MI, or severe recurrent ischemia, or recurrent urgent revascularization 2 weeks after their first presentation. So if your TIMI risk score is 0 to 2, your risk is below 10% to have any of these terrible things happen to you. But there's a jump from 2 to 3, you get in the double digits here, increases your risk. That's why the TIMI risk score says anybody who has an intermediate risk or high risk, you got carte blanche to take them to the cath lab. Ones down here, you got to think about it. Well, I can get by with just a stress test, or if it's a really compelling story, you can still go to the cath lab. But you got to document that why, even though their TIMI risk score is low, why you're sending them to the cath lab. But that's kind of the AUC and the way that it works. Everyone should be completely familiar with AUC calculators and scoring because it's not that hard. Early hospital care, you guys know this. O2 if their SATs are less than 90 or if they look like they need it. Sublingual nitroglycerin, yeah, we all do that. Usually the medics in the ER have already done all this crap for us. If they have persistent ischemia, pain, hypertension, or heart failure, IV nitroglycerin is good. We all know if they have erectile dysfunction or using Viagra or Cialis, nitrates are contraindicated. NSAIDs should not be utilized. Why shouldn't NSAIDs be utilized in acute coronary syndrome early hospital care? What?
Isn't some new research out about NSAIDs actually causing MIs?
There he is, but this patient's already having acute coronary syndrome. Long-term NSAID usage, particularly the COX-2s, increase your risk for cardiac problems. But acutely, it irritates your stomach and you're going to be anticoagulating these people, so don't give them NSAIDs. Unless they absolutely need it. If they need it because they're miserable in pain, the only thing that ever helps is their naproxen. Give them the naproxen, put them on a proton pump inhibitor, document that you feel the risk is outweighed by the benefit. Beta blockers. PO beta blockers should be initiated within 24 hours. Period. Everybody gets PO beta blockers within 24 hours, except if they have CHF at risk for cardiogenic shock, or heart block without a pacemaker, or reactive airway disease. And the key is signs of CHF. If they've got a long history of CHF but they're doing well, they're probably already on a beta blocker and that ought to be continued, which drops down here. Patient stabilized heart failure and ACS, beta blockers should be continued. Again, you'll get this in your CHF talks. These are the only 3 beta blockers ever approved to be given to heart failure patients. Toprol, and Dystolic. We got a lot of other beta blockers, including low pressor, metoprolol, tartrate, and atenolol. Those really are not guideline-directed therapies for patients with heart failure. So try to use Toprol, and Dystolic. IV beta blockade should not be administered in patients who have risk factors for shock. Well, what are the risk factors for shock? Well, they already have low blood pressure. Their EKG shows a large anterior wall MI. Their EF, from previous studies we know, is 30% before this acute coronary syndrome. Don't give them IV beta blockers. This comes from data that when we first started treating with thrombolytics, everybody got IV beta blockers because we showed it reduced mortality. As we did more studies, we showed that patients with large MIs who got IV beta blockers had more cardiogenic shock and more death. So IV beta blockade has kind of been taken out of the algorithms. You can use it, but I would use PO beta blockers and give it within the first 24 hours. Calcium channel blockers, verapamil and diltiazem can be used if there's a contraindication to beta blockade. I think I've done this once in the last 25 years, so, but just know that you can. This is still in the guidelines. Immediate release nifedipine, think Procardia, Procardia XL, should not be administered to patients with non-ST-ACS in the absence of beta blocker therapy. Studies have shown that these rapid-acting dihydropyridine calcium channel blockers make their heart attacks bigger and kill people, and they do that because the vasodilatation increases the heart rate and increases how hard the heart has to work, and you don't want to do that in acute coronary syndrome. But I haven't seen anybody use immediate release nifedipine in 10 years.
Long time.
Yeah, so, but it's in the guidelines, so you don't know about it. Statins are class 1. High intensity statins, 40 milligrams of Lipitor or 10 milligrams of rosuvastatin. Should be used in all ST-ACS if no contraindication. So, I mean, as soon as this patient hits the ER, you're ordering beta blockers, you're ordering aspirin, you're ordering oxygen if they need it, sublingual nitroglycerin, IV nitroglycerin if they have ongoing symptoms or failure, and you're starting statins up front. Don't wait till tomorrow. Write the orders on the bishop. And we should be going with high intensity statins out of the gate. Don't play around with 10 milligrams of Lipitor. Not enough. Don't use Simva. There's data that shows that Simva might actually impair the dual antiplatelet therapy of aspirin, Brilinta, or Plavix. So don't use Simva. There's recent studies out that shows the older patients, I think the cutoff is 75 years, you probably should use low-dose statins because long-term quality of life issues and increase statin intolerance in the older population. But when you first admit them, I don't think it's wrong to hit them big and hard. You can always decrease it on discharge. I'll buzz through this. You always know if their EF's less than 40%, they got hypertension, diabetes, or stable coronary or stable chronic kidney disease. ACE inhibitors are good. If they can't tolerate an ACE, you use an ARB. And then same thing, if their EF's less than 40, they got diabetes or heart failure after standard guideline-directed medical therapy, you got to add in aldosterone. But that's in the guidelines for acute coronary syndrome. So you can't just treat the patients for only their acute coronary syndrome. You got to be thinking about the CHF angle too.
And do you mind just maybe talking a little bit about the definition of chronic kidney disease? Because I think a lot of people kind of misinterpret that. I mean, you know, they have a creatinine of 1.6 all of a sudden.
Don't talk about creatinine, so it's got to be creatinine clearance.
Sorry.
So if their creatinine clearance is less than 60, it's stage 3. If it's less than 30, it's stage 4. And if it's less than 20, it's stage 5, I think. Anyway, those are the, so I don't care what their creatinine is, but their creatinine clearance is important. But if they're stage 3, if their creatinine clearance is anywhere between 30 and 60, use the ACE inhibitor. It's appropriate, and studies have shown that it'll decrease their risk of progressing on to dialysis. So it should be used and pushed. Older doctors are still scared about using ACE inhibitors and ARBs in patients with renal disease, even though it helps the patients. It's a little frustrating. More frustrating for you guys than me. Is that what you want to try?
Yep, that's exactly what I wanted. Thank you.
Antiplatelets, non-enteric coated chewable aspirin. So when they first present, don't be giving coated aspirin. Chewable, don't do 162. Give them 365 up front. There's no difference in any of the studies, but just make it simple. Use 365. All patients, and it says non-STIACs, but it's really all patients with acute coronary syndromes, STEMIs, etc. Give them 365, shoot up, then give them daily aspirin. Again, this some people screw around. They just give 81 milligrams. It's simple and it's easy. I think that's what most people do. as we'll get in, 81 is approved in the US for Brilinta usage, although I think that data is flawed, but that's what the guidelines say. So use 81 on a daily dose. Aspirin in eligible patients should receive a loading dose of Plavix 600, and followed by daily dosing should be administered 75 a day. In addition to aspirin, all patients should receive loading doses and daily doses of Plavix and Brilinta. This is class 1. That means don't wait to add in the Brilinta or Plavix till tomorrow or until their cath is done. Now you guys will get run over by a freight train because you'll have given them 180 of Brilinta in the ER. They go to the cath lab and they've got left main and we want to send them to the OR.
And then we're cussing.
And we're going to blame you. Well, who gave them that damn Brilinta? Most major quaternary facilities with surgeons will take those patients to the OR on Brilinta or Plavix, even with a loading dose a couple hours ago. They just need to put on their big boy pants and do it. The guidelines say it's class 1 for you guys to do this. So when somebody tries to throw you under the bus, well, why'd you give them 180 of Brilinta? Why didn't you wait until we capped them? You can say, because the American College of Cardiology, the American Heart Association, SCI, all says it's a class 1 recommendation for all patients with acute coronary syndrome. And then if they give you more grief, call me. Because they aren't practicing guideline medicine therapy, and maybe we need to discuss that with them.
And if they're unstable with left main, they're going to the OR regardless.
Or I can fix it. But the guidelines say...
He'll put his big boy pants on.
Yeah, because you got to do what's right for the patients, and if that left main is 99%, we know because of the way acute coronary syndrome, there's active clot there. So by treating them dual antiplatelet therapy, you might keep that left main open such that they get to the cath lab and then they can get to the OR. People don't think about that because the surgeons are just thinking, well, there'll be more bleeding and I'll have more complications, and then people will be looking at my report card that I have too many bleeding complications.
But there is real bleeding and real complications.
Well, there is real bleeding and real complications, but you know what? There is absolutely no
But they are
bleeding.
still alive.
There is no bleeding when the left main occludes.
That's right.
No bleeding at all. And the surgeons don't think about that. The surgeons don't think about that because once the patient dies, the surgical consult goes away.
Oh my gosh. True, touche.
And that's what's called the Darwin therapy of surgical consultation.
Right.
I'm going to stand
Natural
back. This
selection.
patient is sick and I might have a bad outcome, so I'm going to stand back here for a couple of days waiting for the Brilinta or Plavix to go down, getting vein mappings, getting a pulmonary consult, doing PFTs, checking, waiting and waiting.
Darwin.
And if the patient survives 5 days, they're probably going to survive surgery. But if they die before that, well, yeah, they probably would have died with the OR. I get the surgeon's point, but it's not valid to cardiologists. It's Darwin, survival of the fittest. If they survive the first 5 days and they're really, really sick, they're probably going to do okay regardless of what we do to them. It's the Darwin therapy of surgical consultation. Prasugrel should never be given to patients with any history of CVA or TIA. I don't think anybody's using a lot of FEN anymore, and I would say steer away from it. There'll be some cases where patients can't tolerate Plavix or Brilinta, I guess, and it's in the armamentarium, pretty rare. Anticoagulants, class 1, enoxaparin, 1 milligram per kilogram Q12 hours, Q day if they have stage 4 chronic renal disease, creatinine clearance less than 30. But if they got stage 3 chronic kidney disease, then they get it 1 milligram per kilogram Q12 hours. Bivalve can be used with a loading dose followed by a drip, only for patients who are going to the cath lab for PCI. Bivalve is really expensive. Fondaparinux we don't use much, but it's 2.5 milligrams sub-QQ day. Can't be used if they're going to the cath lab. Another good reason we don't use it, it's also expensive, so probably ignore that. This is good. I like Lovenox. I'm a radial first guy, so I don't care that the Lovenox is around for 8 to 12 hours really doesn't bother me. My bleeding rates are 0 transradially. So if you want to give them Lovenox in the ED for acute coronary syndrome and then send them to a cath lab, I say okay. Unlike the surgeons, if you give them 180 of Brilinta and 325 of aspirin and 1 milligram per kilogram of Lovenox, I can take them to the cath lab and I can fix most everything and do it, and I wear big boy pants almost every day because it works. I will tell you that when you give this sub-Q, the patient's really not anticoagulated very fast. Another way to do this is you give 30% of this dosage. So if they're 90 kilograms, give 30 milligrams IV, give the other 60 milligrams sub-Q. And I'm okay with that. And that works, and I feel comfortable with it and don't feel that I need to do anything else. But the important thing is, this is cheap, easy, tried and true. Give them 60 units per kilogram bolus of heparin and follow that with 12 units per kilogram per hour infusion. All these things are doable, but they're all either expensive or complex or other issues. I think this is what we should do. It's class 1 in the guidelines, not that the others aren't class 1, but use unfractionated heparin. It works and it's cheap and it's good stuff. We know how to deal with it. And you probably won't get in trouble by any cardiologist. I don't think we should use bival. I know a lot of my partners use a lot of it. We shouldn't. It has not been proven to be better than unfractionated heparin, and it is a lot more expensive. There's also some cases where it's been proven to maybe worse than heparin. I'm not going to get into this, not the point of this talk. This is yellow, means it's a class B or class 2 recommendation, not 1 or 3, but I threw it in here. Left heart and PCI within 24 hours of admission of non-STX patients, or a delayed left heart cath within 25 to 72 hours for stabilized high-risk patients or non-high intermediate risk patients is appropriate. We should know that and know how to deal with it. If they're really high risk, treating them, stabilizing them, and then taking them to the lab within 25 to 72 hours is appropriate. That's kind of the cardiology Darwinian theory, because I don't want cath lab deaths, so kind of tune them up if they're really high risk. But the vast majority of patients, if they come in with a non-STX, need to be going to the cath lab within 24 hours admission. That's a 2B indication. This is critical. Class 3, it's in red. Don't do this. Early invasive strategy to read heart caths should not be utilized in patients with extensive comorbidities in whom the risk outweigh the benefits of the heart cath. Or think the 90-year-old demented patient who's got an INR at 35 who comes in with chest pain that's now relieved in the emergency room, and their EKG doesn't show a STEMI, but it's abnormal, and don't send them to the cath lab because I'm more likely going to hurt them than I am to provide this patient any short-term or long-term benefits. I think this is especially gender aggressive. This is a microaggression by the ACC. Don't send them to the cath lab in low-risk patients with acute chest pain who are troponin negative. I put it in quotes, it's right out of the guideline, especially women. Class 3, low-risk women with acute chest pain who are troponin negative should not be considered for an early invasive strategy. Now, I know we don't do that. I know we take these women to the cath lab. But you guys need to know what the guidelines say. Guidelines say it's class 3. Those patients should go and have a stress test and only then go. I'm not sure I agree with this. In fact, I think it's wrong.
And they're
to
talking
say.
about like less than age 60, you know.
This is how the guidelines say. I'm Asperger's. I don't make shit up. And low risk patients. So if their TIMI risk score is less than 3, but they have acute chest pain and their troponins are negative and they're women, then they probably should have a stress test by the guidelines. I believe. I won't go there. Discharge medication. So they come in, we've taken good care of them. They got to go home on sublingual nitroglycerin. That's a class 1. If you don't and they have a heart attack, that's malpractice. They got to go home on aspirin. 81 is what I said we should do just to be consistent throughout Prairie. Has to guideline directed. The dual antiplatelet therapy has to be Plavix or ticagrelor, even if they didn't go to the cath lab. If they're the high-risk patient that you never sent them to the cath lab and you just wanted to treat them medically, the appropriate medical therapy is dual antiplatelet therapy. If they went to the OR and got cabbage, send them home on dual antiplatelet therapy. They do better. It's class 1.
Can you
Yes.
go over the duration
No.
of dual antiplatelet therapy post-revascularization? 1 year?
No. 1 year.
Oh.
Yeah. Beta blockade, class 1. Send them home on beta blockers. Beta blockers, great. Statins, class 1. Do it. And then the ACE, ARBs, aldosterone inhibitors are in the appropriate patient. Antioxidant vitamins, EC, beta carotene, no. Class 3. Folate, no. B6, B12, no. Class 3, they don't help these patients at all. There's no data that shows that. COX-2 NSAIDs and hormones should not be used unless the risk outweigh the benefits, which means you have to document this. The current recommendations, and again about quality of life. If this 84-year-old person comes in with a STEMI or non-STEMI, I put a stent in. If they have such terrible arthritis that they can't do anything, they can't go to cardiac rehab, much less get up and walk to the bathroom. It's about quality of life. In that case, I think the benefits of giving them naproxen, ibuprofen, whatever you like to give, is of benefit. But if they're taking, oh yeah, I get a headache and I really like to use ibuprofen, no, don't use it. Use Tylenol. Suck it up. Yes.
On the vitamins, the folate, B12, what about like the chronic macrocytic anemia patients and that? Is it
Different
harm
indication.
or is it just?
What this is from ACC, there's no harm, but
Okay.
there's been no cardiology data that shows that any of these things help from a cardiac
From a
standpoint.
cardiac- so
If
they
you
were
have
on for
another
another reason?
indication,
Okay, I just want
do
to make sure
it.
it wasn't harm.
Which is similar here. I mean, we've proven
Right.
that hormone therapy and NSAIDs don't help the patient. There may be some harm in them, but if there's another compelling risk to use it, you should use it.
Gotcha.
Can
Done.
you talk about CoQ10? We've seen a resurgence of primaries starting people on CoQ10 when they're on statins.
Yeah, no, yeah, they think that reduces statin myalgias. It doesn't. It's a placebo effect. But we have no studies that show CoQ10 hurts anybody, and there's some small trials that say it might help people. So in you don't want to get crosshairs with the primary care doctor. Let's just leave them on their CoQ10.
Sure,
It's
whatever.
not going to help them. But if the patient says, I'm taking too much damn medicine, you say, well, the data says you might not need CoQ10, and get them off at that one. The ETCC stuff, I think what Char has done and you guys have done with CU7 is critically important and even more important moving forward with the environment that we're in. We've got to get these patients back in the office and be seen to really tell them in a non-hospital setting that they need to take their medicines and they need to quit smoking and they need to follow up. It allows us to check to make sure everything's going okay. This is really going to be important moving forward, and we're ahead of the curve. Cardiac rehab has to be ordered on everybody in the hospital. I write my orders for phase 2 cardiac rehab while they're in the hospital. I put it in my post-cath orders. Phase 2 cardiac rehab on discharge. That way they aren't lost in the follow-up. Well, we wanted to get them in phase 2, but we didn't have an order from your office. Take that off the table, put the order in somewhere while they're in the hospital. Tobacco cessation education, that's class 1 guidelines. Pneumovax, influenza vaccine, all class 1 in the guidelines. This is touchy-feely. Most patients, I tell them the reason we're doing all these things, giving them all this medicine, hurrying them out of the ER, getting them into the cath lab very early, and doing all these things is to allow them to maintain whatever activities they were doing before the hospitalization. Particularly the younger patients, when they come in with an MI, they feel their life is over, and that's not the case. They need to be reassured, you're going to be able to go back to work soon. You're going to be able to have sex soon. You're going to be able to exercise and should be exercising. And with ACS, we're probably extending their life. So managing their expectations, and you say, you know, you did have a heart attack. I know you feel good sitting here in a hospital bed. When you get home, you might feel a little more fatigued. We're going to have to work you back into it. Cardiac rehab's going to help you with this to understand the expectations. But we absolutely feel that you're going to be able to go back to your previous job, which might involve sex, or you may be able to go back to sex and exercise very quickly. And that's the importance of cardiac rehab, blah, 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 blah. So prop all the patients up because they all feel their life is ended, be it young or old. Reassure them that no, the reason we do all this crap is we don't want you to go home and sit in a recliner or go to the nursing home. We want you to return to an active lifestyle.
The request for the long-term disability paperwork.
Yeah.
After the revascularization.
Yeah, that's a different,
Nope.
different scenario altogether.
As soon as it comes
This is stuff you guys should know. If you don't know, I would be embarrassed. Primary PCI in STEMI patients with symptoms less than 12 hours. So they got a STEMI, they got symptoms, it's inside 12 hours, you gotta send them to the cath lab. Send them to the cath lab for PCI and STEMIs who have shock or severe heart failure, irrespective of how long the MI has been going on. It can be going on for days, but if they got shock, they gotta go to the cath lab, they'll get an Impella and they'll probably get PCI. It's the only way to reduce their mortality. Primary PCI with clinical or ECG evidence of ongoing ischemia beyond the 12-hour window. So if it's 24 hours, but they're still having chest pain or the EKG still shows ST elevation, class 1, get them to the cath lab for PCI. Initial care summary. Do the H&P, which we kind of went over last time. What's their chest pain? What's their risk factor? Is their chest pain atypical chest pain? Which no one's going to say.
Correct.
Is it non-cardiac chest pain, atypical angina, or angina? What's their Canadian Cardiovascular Society class? What's their TIMI risk score? All that stuff. Medications, DAPT, beta blockade, statins, and heparin. EKG for everybody. We talked about repeating the EKG, and we talked about troponins. TIMI risk score for non-STIACs is important to determine appropriate use criteria. And that's a bad slide. What do I do in Indianapolis if we heard that a stat heart was coming? The interventional cardiologist met the ambulance in the ambulance bay. And we started taking our review of systems in the ambulance bay. We did our H&P in the ambulance bay while we're walking to the cath lab. They never went to the ER. The cath lab was about from here to the cath lab, so a short distance. What does an interventional cardiologist want to know with a STEMI that's coming in my lab? And this is one sentence. Mr. So-and-so, you're having a heart attack. We're taking you to the cath lab. I need to ask you questions. Are you allergic to anything? No. Have you used Viagra or Cialis recently? No. Over the last few weeks, have you had any trouble with coughing up blood, spitting up blood, pooping blood, or peeing blood? Because I'm getting ready to give you a lot of blood thinners. And when you look at billing, gosh, I just hit 5 systems and review systems in one question. And if you say it in this terms,
They know what you mean.
they know what you mean. They can be dumber than a fence post. Are you coughing up blood, spitting up blood, pooping blood, or peeing blood? And Char and I come from the same background of working with working people that work for a living. They understand this shit, and you don't have to beat around the bush with them. And have you seen any red material in your fecal material after every bowel movement? No. Have you been pooping blood? I say, oh yeah, something. Yeah, I did 2 weeks ago. Was it bright red and on your foot? But yeah, I got hemorrhoids. Okay, got it. Going to the lab. So by the time you talk about their chest pain, shortness of breath, these things, you're talking to them so they're awake and alert. You've got like 7 or 8 systems and review systems. All of a sudden, you're starting to upcode how much you're billing on this one. So it's quick and it's easy. It's not wasting time. Because if you waste time in getting my patient into my cath lab for me to fix, you're hurting my data. So don't waste my time. Do this while you're walking with the patient. Cases, good. How are we doing on time? Where are we at?
Good. Yep.
Okay. I got some fun cases. 66-year-old male. Presents the ER with 30 minutes of stabbing chest pain that radiates to both arms, jaw, and back, and is associated with dizziness and shortness of breath. How would you characterize this chest pain? Non-cardiac chest pain?
No.
Atypical chest pain? No. Everybody should know it's not atypical chest pain. There's no such thing as atypical chest pain. is a typical angina. Really not, this is not a characteristic of typical angina stabbing. It's usually a discomfort, a pressure, a weight, a tightness, blah, 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 blah. This is atypical angina by description. He had similar symptoms off and on for the last 2 to 3 weeks. So you're already starting to get a picture that, yeah, this sounds like the real meal deal. And then he's got risk factors out the wazoo. He's got hypertension, hyperlipidemia, hypertension, history of coronary artery disease, but he's not diabetic. So I can tell you Timmy risk score just with this data, and we haven't even looked at anything. If he's a non-ST segment elevated myocardial infarction or unstable angina, he's at least intermediate just because of his age, just because he's had more than 2 episodes in the last 24 hours. He's got 3 risk factors, and he's got a history of greater than 50% stenosis in his coronary arteries. So he's already at a 4, even without looking at his troponins or aspirin usage or EKG. Here's the EKG. Who wants to read the EKG? Read the EKG. Jenna, read the EKG. And if you read what's up here, I'm going to kick you out of the lecture.
not.
Here, I'm going to go here so you can see it better. I got a better slide. There you go.
Okay.
What's the rhythm?
Oh. Sinus.
L.
No.
Here's your rhythm strip.
Yes, please. You say no?
It says that all.
Oh, no.
Normal sinus rhythm with frequent premature ventricular contractions. This is PVC, 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 PVC. That could be that's probably a fusion beat, honestly. Could be a PAC. Probably a PAC looking at it. So it's a normal sinus rhythm with PAC and frequent PVCs. PVCs are in a bigeminal pattern. All right, now go to the stuff you wanted to look at because you knew it was an ACS lecture.
Well, you got me all messed up because maybe you did it before.
Good, I'll show it to you anyway. We've got ST segment elevation in V1, V2, and V3. How high does the ST elevation have to be in these leads to be considered a STEMI in a 66-year-old male?
Way too. 2 millimeters?
Yeah, 2 millimeters. I think it's 2 millimeters in V1. This is a PVC, you can't count it, so you can count this one and that one. I think it's right. It may not reach 2, but it's really damn close, right? So I would tell you that I probably wouldn't recommend lytics by the guidelines. But everybody agrees this patient is having acute coronary syndrome. He's got all the risk factors. He's got symptoms of atypical angina. He's had multiple episodes. And his EKG really looks like he's having anterior septal ST segment elevated myocardial infarction. You see the reciprocal changes here inferiorly, which goes with it. So that boy, right now we're rocking and rolling. This guy's got something hot. Here's the rest of the data. Hemoglobin's 15, platelets are okay, white blood cell count's okay, renal function's okay. They weren't convinced by his story or by his EKG, so they did a chest CT and chest X-ray, which were unremarkable. He's not having a PE, doesn't have, hasn't dropped a lung, doesn't have a large pericardial effusion, and his troponin was abnormal at 1839. They did treat him with aspirin, Plavix, Lovenox, Dilaudid, and morphine. So what do you guys think?
What did they do? Is that what you're asking?
What would you guys do?
Is he still having chest pain?
Must be Dilaudid, morphine.
No, he's not having any chest pain because they're kitting him with Dilaudid and morphine.
Right.
Where's his nitro?
But you've got enzymes, EKG changes, and pain, so.
Repeat
Cath lab.
EKG.
Yeah, and I would say beta blocker and statin. I mean, he's got troponin leak, he's got an EKG, it looks like a STEMI. This is contraindicated. This is only if it's not going to slow us down. This patient was admitted and admitted with this shit. Wasn't even admitted with beta blocker, statin, IV nitroglycerin. Admitted with that and put it on the floor.
He didn't get any nitro, did he?
That's wrong.
So I agree. I've taken this guy to cath lab. Here's his films. Left main. This is his left circumflex. That's his LAD up there. Where are we expecting the lesion to be from V1 and V2 ST elevation? Anterior wall, which means what artery? LAD. Here's the left main, the circus coming out at you here. Here's his LAD. The LAD should come all the way down like this. It doesn't.
It's okay.
Here's now a wire down the LAD. That's where the LAD should be. It's the same view as last time. This is a balloon up in the mid LAD. But see how this artery from here all the way down here, it ain't moving. See how this stuff up here is beating and moving? This ain't moving. Why isn't that moving?
These are ACS.
It's dead. It's because they waited like 24 hours to get this patient in the cath lab who had ST elevation darn near worth giving lytics to, who has known coronary disease, all the risk factors known to mankind, continuing chest pain requiring dilaudid morphine, and the patient didn't get to the cath lab for 24 hours. Time is muscle. It's a great example of time is muscle.
I hope this wasn't our hospital.
It's Prairie. Case 2, 77-year-old female presents to the ER with severe band-like chest pain that radiates to the back associated with shortness of breath. Onset 5 hours ago. Has a history of coronary disease. Has had PCI. It's got hypertension, hyperlipidemia, tobacco, but no diabetes. What's her chest pain? Typical angina. Absolutely, this is typical angina. So you take a 77-year-old female, typical angina, known coronary artery disease, multiple risk factors, Bayesian theorem that we talked about 2 weeks ago. What are the chances that this is the real meal deal? It ain't 100, but it's really close. Physical exam was unremarkable. Her labs are unremarkable, except that she does have stage 3 chronic kidney disease. Her troponin is 31.
But we can't diagnose that from creatinine though.
With creatinine clearance, that's right.
Are you gonna trend those troponins just to make sure that?
I had to do
I'm
it.
not sure I believe that she's having a heart attack, so I think we need another troponin. Because maybe it's 31 because she's got bad kidneys. Exactly, maybe. And I'm gonna,
I'm glad you guys are all so sarcastic. I love
you
it.
should be so.
I know.
Here's her EKG. What do you guys think? Jenna, you're on. What's her rhythm?
She's in sinus.
What's her rate?
Can I look up a top for that?
Well, you shouldn't, but yeah, you can.
Well, if I could get close enough to it, I could tell you.
I'm old and blind, and I can tell you it's pretty close to 60. It's 5 boxes. Okay, what's it say up there?
63.
Okay. What else do you want to say about the EKG?
Left axis deviation.
No, it's up in 1, up in 2. It's normal axis.
She has only ST elevation is in V1 and V2, but V2 is depressed. V1 is depressed.
And 5 is depressed.
4 and 5.
How much ST elevation is V1? How many millimeters?
At least 1,
Okay.
maybe 1.5.
How many here?
Like 1.
I agree. How much here? I mean, I think there's ST elevation there.
Yeah.
Probably there. Yeah. So this is really close again to meeting classification. In women, it needs to be 1.5 millimeters in height in these leads. This is really close. I agree. I think that's close to 2. I think that's 1, and I think that's maybe under 1. But you know, she has. She's having an event. I wouldn't give this patient lytics by the guidelines, but I'd get her to the cath lab pretty darn quick. Any other comment? And then the reciprocal changes you talked about.
What about the 4 and 5 ST depression?
Yeah, that's a reciprocal change from her anterior. So you guys want to send her to the lab, I hope. Okay, so she goes to the lab. Here's her right coronary artery. Nice, big, beautiful right, but we aren't expecting a right, we're expecting an LAD. So what do you look for in this picture?
Collaterals.
Yeah, exactly. See, Dawn's been in the cath lab. you're looking for collaterals. Maybe the LAD's closed. If you start seeing collaterals from the PDA out here going up to the LAD, you know the LAD's closed. Here it is, left main, left circumflex, LAD, diagonal branch. Yeah, see a previous stent, if you remember on history, she had previous PCI. Here's the LAD, stent here, blood stops here. You see a little bit of collaterals filling it from the other diag, actually a diag to distal LAD collateral. So, I mean, she is having a STEMI because she's occluded her mid-LAD right just proximal to that stent.
Do you shoot the right first in this patient, or?
I don't. I shoot the
Okay.
infarct-related vessel with a guiding catheter because if their LAD is occluded, I don't care what their right looks like.
Right.
It's
They know
wasting
where-
time. I need to get the artery open, put a stent in, and then go back and check all the other arteries.
But if it's a right
Drives me
infarct
crazy.
artery, you don't go straight to the right. You still shoot the left. just in
Inferior
case.
wall STEMI, I put a guide in the right, put a stent in the right, and then I go shoot the left.
What-
Let's say they're having an
what-
inferior wall STEMI with an occluded dominant right coronary artery,
And you spend time trying.
and they have a 99% osteal left main. I know that patient's going to do better if I stop their heart attack, revascularize their right coronary artery, and then send them electively to cabbage. They're going to do better. So I think the cardiologists that wuss around and take a full set of diagnostics,
And shoot an LV
they're
first.
wasting money and they're wasting time. Just
Yeah.
like I don't want you guys to do the full bore review of systems. Are you coughing up blood, spitting blood, pooping blood, peeing blood is what I need. Because if you're wasting time, you're killing muscle. I don't waste time and kill muscle in the cath lab. Yeah, but that is personal preference among interventionalists. But if any of you come in with a STEMI, I'm putting a guide in whatever vessel I think it's going to be, and I've already got a wire, and I'm going to open you up, and then I'm going to figure out what you have. So here's the wire down, balloons in, balloon fixed her. Here's the result. So it was occluded right there. Got that open. This is wiggling a little. Not like the other guy, but not robustly. It's not wiggling like these vessels up here. 5 days later, same patient, 77-year-old female. She presents back to the emergency room with crushing chest pain. If you remember previous, it was a band-like tightness. Now she's got crushing chest pain with radiation in the left arm. Does have shortness of breath, and it started again about 5 hours ago. She was in her nursing home after discharge after MI. But they didn't have ticagrelor, so they just treated her with aspirin. Now she rolls back in with different chest pain. CBC and BMP are not changed, so we didn't burn her kidneys with everything we're doing. And her troponins 1.3. So what do you guys think right now?
She's a clinician.
Think so. So you're calling me right now. You don't want any other data. You're saying, God damn it, she's a stent thrombosis. She needs to go to what?
EKG.
Yeah, let's get an EKG. Jenna.
She's still a sinus. She is not elevated in the B's. But 5 and 6 are depressed.
Remember, she had a lot of ST depression out
Yeah.
here, and she has some in
Okay.
2, and I think F. She doesn't have any real ST elevation, V1, V2, or V3.
Great
And her
part.
reciprocal, that's because she's on a beta now. Her, this is a better looking EKG. So I got called by the nurse practitioner, says, oh, we want you to take this patient right to the cath lab. She's having chest pain. They didn't have her in Berlin. We think she's closed her stent. I went and saw the patient, and she didn't look like she was that sick. And I looked at DKG. I said, I don't think she's occluded her stent. The first time we saw that she occluded her stent, and she had ST segment elevation. If she had ST segment elevation the first time around, you can bet she's going to have it the second time around. But I said, I don't think it's inappropriate to take the cath lab because she did present with terrible chest pain and the Berlinta stuff. I'm not going to be foolish and prideful and sit on her. I took her to the cath lab, but I said, I don't think it's going to be closed. Left main, left circumflex LAD. Here's what we want to see. Everything's patent. It's open. EKGs don't lie. EKGs don't lie. What's causing her pain? Hell, I don't know. Is it this lesion up here? Is it aspirin? Is it acid reflux? I mean, her pain is different than her previous pain. I don't know. I don't know, but I went ahead and IVISed all this just to make sure we weren't missing something angiographically to look. But we got her back on her parental. She went home. She did well. But that's kind of a nice example that if they had ST elevation when they're real MI, when they come back in and they don't have ST elevation, probably not the stent. When stents close, you have ST
EKG's gonna
elevation.
show it.
Yeah. When stents occlude thrombotically acutely, the EKG is pretty damn diagnostic. So remember that. Case 3, 72-year-old male, known MIs in the past. He's got moderate to severe left precordial chest discomfort without radiation. He does have shortness of breath. It's been going off and on several hours, but has been sustained over the last 45 minutes. Good medicines: aspirin, toprol, atorvastatin, lisinopril. All right, I'll do the EKG. This is irregularly irregular. This is atrial fibrillation, PVC. It's got ST elevation and AVR, which we don't care about, and then diffuse ST segment depression everywhere else. Everywhere else. I got called on this, I forget, a couple of weeks ago, the ER, and they said, we've got a STEMI, we've activated your cath lab, we want you to come in. I just gave you the criteria for STEMI by the American College of Cardiology and American Heart Association. It in no way ever included just having ST elevation and AVR and diffuse ST segment depression. So this is not a stat heart, not a star 90 by definition. Now this patient can be really sick and have terrible crack going on, but it's not a star 90. And that's important. The ER doc says, well, I read that if they have ST elevation and AVR, that it's probably a left main occlusion, and it's a STEMI. It's a left main STEMI. I said, I haven't read that. That may be true, but it doesn't meet guidelines for a STEMI for activation of the cath lab or thrombolytics. But I said, I'm not saying that we might not have to take him to the cath lab, but it's not a STEMI. It was at 2 in the morning. I didn't want to really get into a long discussion with him, but I think he heard me because I was using more of the daddy tone than I'm using with you. So what do you do with this guy? 45 minutes of sustained chest pain, known coronary disease, history of MIs, multiple risk factors, this EKG.
This would be, he has ST depression, so I would do nitro, heparin, and see if we can resolve his pain.
Is that all you're doing, nitro and heparin?
Well, you've already got beta blocker, aspirin is on board, right? And statin was already on board.
So you're going to continue all
I'll
that?
continue all that, yeah.
You're going to load him, aren't you? You're going to give him 180 Berlin, aren't you?
I thought he was on, wasn't he on Plavix on
Was
the
he?
other one?
You probably
was.
right.
I don't know, maybe he wasn't.
No.
Oh, no, he wasn't, okay, yes, I would load.
Good.
Okay.
That's what I would do. But then, if those things don't work and he's still having chest pain, yeah, you gotta get him a lab.
Yeah.
You gotta get him a lab. I agree wholeheartedly. Here's his EKG like 2 hours later. Yeah,
Great.
you see he's back in sinus rhythm.
So was it?
All the ugly ST segments changed. They're back to baseline. Here's his cath. Now it's the next morning. Take him electively because his TIMI risk score is high. I'm taking him to the cath lab. Right coronary artery, CTO in the os. This is, well, you see the collaterals filling the distal right. This is a CTO in the circumflex. Late here you see right. Here, his collaterals to the circumflex. This is his LAD. Again, LAD, these are all the septal perforates. The right's lightened up by collaterals. It's the dominant right. I think I have one more here. Again, LAD up here, and here's the circ collaterals here. So the circ has a CTO, the right coronary artery has a CTO, the left main's fine, the LAD's fine. Why did this patient have such an ugly EKG and 45 minutes of chest pain?
Because it was in
When you said
atrial
he did.
rhythm.
Exactly. He had AFib with rapid ventricular response. His
Increasing.
myocardial demands were up. His heart had to work harder. 3 hours before he was fine because either he didn't have rapid ventricular response or wasn't an AFib. This is a patient with terrible coronary disease with 2 CTOs, which are known, by the way.
Wouldn't that have been fun at 2 o'clock in the morning?
And if you remember, he has a history of 2 MIs.
Yeah.
Right, there they are.
Well, there they are. And that was several years ago. So this guy's had 2 CTOs, his circ and right, for several years, and was doing fine until acutely something changed. Did his hemoglobin drop to 4? Did his blood pressure go to 190? Did his heart rate jump to 130? Those are the things you look for. But so now electively I take him the next day. I say, you got 2 CTOs, and I can open those, but I think really the osteal right is complex, the osteal circumflex from a CTO standpoint. This patient needs to talk to a surgeon, but the key is, once we got him back in sinus and got him on appropriate medical therapy, he can talk to the surgeon electively in the office, and the surgeon and I can discuss the risk and benefits and heart team approach. Do we do CTO PCI, or does he go and get bypasses? And we can bring the patient in on that discussion. We aren't doing it at 2 o'clock in the morning. That's appropriate care, and why, if you follow the guidelines, more often than not, you get to the best outcome for the patient. You deviate from the guidelines, you start getting in uncharted territories that we don't know what goes on, you don't know what to do, and your chance of a bad outcome increases. Wasn't that a great case? I love that case. I mean, a great example of the reason is EKG, and honestly, you could almost say that the ER doc was right. It kind of is kind of like a left main. This patient was having fairly global ischemia, but he's wrong on his EKG. 76-year-old male, known CHF due to a bad pump. They don't know why. What are the etiologies of left ventricular dysfunction? Quick.
Oh,
Ischemia,
ischemia.
myopathy.
Oh, that's weak people.
Valve
Weak.
disease.
How about hypertensive heart disease, valvular heart disease,
Viral.
infiltrative heart disease, cardiotoxic drugs? Not all CHF is due to myocardial infarction.
Viral syndrome.
You got a viral syndrome, very good, yeah. All sorts of things cause this. Patient presents not feeling well, mild decrease in level of consciousness, that's a high risk factor. You go whoop, whoop, whoop. Chest discomfort, yeah, well, they really aren't talking too much, so it's kind of hard to really know if they're having chest pain or shortness of breath. You know. Are you having, okay, that
Yes
sounds
to
like a yes to
everything.
me. Multiple admissions for CHF. Now he's a DNR at home. Just was in the hospital a couple of weeks ago, was made a DNR at home, not hospice, but DNR. And they put a Foley catheter in because he was incontinent, da-da-da-da-da. He is on good medicines, aspirin, carvedilol, atorvastatin, Lasix, and potassium. So you're worried, is this a STEMI? Is this guy coming in with a STEMI? I mean, you really, by history, can't get much, but you could probably make the case. Well, he says he's having it. So it could be a STEMI. Here's the EKG. Jenna, read the EKG.
Oh my god.
I think I didn't blow this one up. He's paced. He's paced. But I look at this EKG and I know exactly what this EKG is because I've seen it enough times. I know what this EKG is. Let me tell you, his previous EKG from just a week ago looked like this.
Whoa.
What's this EKG? Sharp.
Is this like slow BT? It's wide.
He's paced. It's also VT, he's paced. Can't you
He's
see the
being
pacing
paced?
spikes? Yeah, if you get up there, these are all paced.
Oh, those are all
There
pacer.
are pacer spikes
Oh, okay.
with each one of these.
Okay.
Aren't they? Jenna's closest. That's why I keep.
Is he heart block? Yeah, I see.
Yeah, there are pacer spikes with each one of these.
Oh, okay.
You can see them down here.
They're small.
He's done her block. Okay. From your old school geometry.
Geometry?
Yeah.
Oh my god, are you kidding me?
What does this
Well,
look
there
like?
would be-
Follow the green dot. What's this look like? Looks like a sine wave. Doesn't it look like a sine wave? This is a sine wave. Does that spark anybody's thought? Okay, I'll give you more of the story. A nurse practitioner was called over the weekend prior to this presentation that the patient was feeling a little bit better at home with their Foley in, but still short of breath. That was fine. He was only on Lasix once a day. She appropriately doubled his Lasix to BID because he's a DNR. We're trying to make him feel better. She appropriately doubled his Lasix to BID and doubled his potassium to BID. His creatinine, I don't know his clearance, but his creatinine a week ago was 3.7.
So it's hyperkalemia.
This is hyperkalemia. When you see this and you know what just a couple days ago it looks like this, and then you look in the chart and find out that they don't have normal kidneys, this is a K of about 7.
Wow.
Would it look like that even if he wasn't paced?
Yeah. Yeah.
Hmm.
Yeah, this is what hyperkalemia does. The T waves get really tall and big out here. They get really wide. The QRS widens. The PR widens. It becomes a sinusoidal wave. This is a couple days ago. This patient died shortly after admission. No one in the chart. I don't even think he died in the ER. I don't even think they got labs back. But, which isn't, I mean, he was DNR, he had terrible quality of life. But his potassium shouldn't have been doubled without a little bit of chart research. And I all know how we get busy on the weekends. It's not a perfect system. I'm not blaming anybody. I'm not blaming the nurse practitioner. I can tell you there's 80% of prairie cardiologists that would have done exactly the same thing over the phone on weekend call. This stuff happens, but you guys need to know this stuff happens and it needs to click in. Yeah, I'm going to give them, double their Lasix and better double, wait a second. Does he have any renal issues? You know, hell, he wasn't on aldosterone, but he could have been. Why wasn't he on aldosterone? Because his kidneys were too damn bad. So, the bad case, but I mean, this stuff happens, and I don't think this was malpractice or anything bad, but this stuff happens. It happens a lot. But this I want you guys to know, because I get called for this stuff on call. It's a STEMI. Well, you've got big STL. This is a STEMI. It's a really bad STEMI, and no, this is not a STEMI, and you better check his potassium. What usually happens is their potassium gets a little higher. You ask Cree or one of the other smart guys, and they'll tell you around 7.5. Pacemakers quit capturing. So if you got a patient that's coming in with complete heart block or something like that, and I put a pacemaker in and I can't get it captured, it's probably because their K is like 7, and that's why they're in heart block, and that's why my pacemaker lowers. So pacemakers don't work in hyperkalemia. So I mean, as his potassium increases, pacemaker just shut down. This guy died.